We are all beautifully imperfect.
You need to pay attention to what they're saying.
You deny your weaknesses.
When you get people to appreciate each other more, look out for each other more, take care of each other more, reduce the distance between them, then they actually work better together.
Okay, it's really, really, really important. That's the best way to get rid of pressure. You can all sit down again. There you go. I want to try and stress before we even start this, that's all you have to do. That's the biggest pressure relieving thing that you can do, is you've got to stand up and you've got to get your patient sitting up. If I go to an old age home, I want to cry when I see them all sitting around the edge of the room on their bums, and they're up from breakfast to 4:30 supper, and they get put into their beds, and that's it. They don't stand up, they're not encouraged to move. It's a serious problem. And all you have to do is a lifting round. All you've got to do is go up to each old person, put your arms in a hug. This is my hugs for the day. And lift them up. And guess what? We've got blood supply to the bum. And you get so many hugs and it fills your heart. And that's what counts. That's all it takes. If you sight an IV in somebody's arm, what do? Don't assault the patient. And don't tell them I told you to. But a little tapping on the skin is incredible as to how much blood it'll bring to that tissue to perfuse it. And by doing those two things, lifting a little pat, not, and I'm a really good nurse. How else would I give pressure care? Because I'm trained well. What am I doing to the skin? What am I doing to all the blood vessels underneath? Especially that old skin. I'm tearing and breaking blood vessels. I'm causing bruising. Rubbing stops. You've got to know that. When you're doing pressure care, you need to really, really, really love that skin. And that's, I love your logo. You've got to love that skin. If it's a loose skin, and it's really going to spread like this, it's going to tear all the blood supply, all those little vessels, and you start the precious. It's your fault. Please, lift them, pat them, love them, stop rubbing. Len Davies is my representative from Umsinzi down in Cape Town, and Len is a lovely older man. Anybody here know Len? Apart from the crew. Len is the ultimate character. And Len said to me, would I present Apples to Ulcers, which is an article by Patricia Turner, to help, who's in teaching here in nursing? Who works in nursing and has somebody that you teach as you work? Please tell me it's every single one of you. Because you are now, having been here today, you are the stone. You know, and I'm a stone thrower. When you throw the stone, you create ripples, and I'm hoping you will ripple for me. And this is Patricia's work, it's not my work, and I'm presenting it on behalf of Umsinzi, and I just want to help you understand, and it's just a great concept, and I love my pictures. I hope you're going to enjoy them as much as I did.
And it's in everyone's bag. When you take your bag home today, you'll find a copy of the article. It's in everyone's bag.
All right, great. So I'm going to go through it, but hopefully just to help you, when you pick it up, you're going to be familiar with it, and it's not going to be an article that you throw in the bin on your way out. Put it in the nurse's station, share it with your colleagues. Don't just file 13 this. It's really quite great work. This is what it looks like. It's Apples to Ulcers. Just another different way to think about pressure. What's it about? How common is it in your facility or in your experience that despite numerous references and in-service reviews, that you still struggle staging pressure ulcers? Does anybody understand, everybody know about the staging of pressure ulcers? You've all heard about it, but it's still not too clear. Are the fruits of your labor in your educational plan for your staff not really working? And adult learners are also goal or relevancy orientated. So we like to be respected in what we know. And I was talking about that and stuff and things. We want to be respected for what we know, but you need to be able to share your knowledge in the correct way. So it's really important. So this article is really nice. It kind of brings in an analogy, hopefully, that you'll be able to understand. So when you're explaining it to people, you'll be able to understand and to express yourself a little bit better. And what started it all? In the United States, it is a criminal offense to get a pressure sore while the patient is in your hospital. Well, tell me that one of you hasn't blushed here. Because that's the problem, is people get admitted. The Medicare and Medicaid centers have said that anybody who develops a pressure sore in your facility, they won't pay you for that treatment. That facility and that problem is your fault. You have not protected the person in your care. So you've got a hip replacement lying over there, and he's restless because he's a little confused. He's 95, he's had a hip replacement because he broke his hip. And he's wriggling his foot, and you end up with a pressure ulcer on the heel. It's your fault. It is you who has caused that. And in America, they won't pay for it. The hospital has to pay for it. So in America, they train their staff properly to prevent it. Whereas here, you kind of go ad lib and good luck, you know. Kind of pressure sore, it doesn't matter, your medical aid will pay, and that's it. And now the medical aids are turning around and saying, we're not going to pay. And now we're going to be in trouble. So staging of pressure ulcers and recognizing pressure ulcers when they come in becomes an essential part of what we do. Okay? And it's really, really important to remember that there's this great term, it's a hospital-acquired condition. Very interesting thought. You know, here's a place where you're supposed to be looking after your patient and caring for them and protecting them, and you've allowed them to become injured. It's a really, really, really important part of responsibility that we need to look at. And the most important part is when they are admitted, what is the problem? I've had patients come into me, and I've actually had to go in for a legal consult. They've called me in my advanced wound care portfolio to go and assess a patient for a lawyer, and they've come out of hospital with a pressure sore. But what wasn't done was they didn't acknowledge what happened before she went in. And before she went in, her son would go to work, he'd get her up, put her in a chair for the day, let her pee and poo while sitting in the chair, the whole day cut, and come home 8 hours later, clean her up and throw her into bed. And they say the hospital was responsible. And there has to be a role, there has to be an acknowledgement. When you're doing an admission, and every time a patient gets admitted, you have to remember it's about the whole within the whole. What is the patient's history? Are they a soup and toast granny? Because in the old days we made soup. We eat in a pot with vegetables for 3 days. It was a good soup. Nowadays, Knorr, Maggie, in a packet, pour some boiling water on, cook some white toast, and tell me what the nutritional value of that meal is. They do soup and toast for supper, and they do tea and cookies for lunch. And you've got to remember that when these patients come in, look at them as an entire patient. And remember, everybody comes in with a history. All right, so in the course of the hospital stay, the patient stay, you should be doing frequent inspections as well. And it doesn't help for somebody to be just glancing over it and not remembering to record it, report it, create the communication around what you're seeing. It's really important to put your hand on the skin, especially if it's a darker skin. You might not see the right things, but when you touch a patient, you need to be able to feel the heat and know that you're getting into trouble. So you've got to use all your senses at every nappy change, at every wash, at every time you deal with those patients. And you need to report it and assess in a continuous basis and then act proactively when you find something. What is a pressure ulcer? It's a localized injury to the skin. Hopefully it's localized. Sometimes patients get into bigger trouble, but we're hoping for a localized area of pressure, usually over a bony prominence, as a result of pressure or a result of pressure and shear and a number of other contributing factors. Now, what is shear? Just take your hands, rub them together. Got some heat, nice and hot, that's shear. Okay, and you're shearing off that raw thorny layer, you really are starting that damage. And every time that patient slips and slides on that bed, that is shear. And we put them on a plastic-covered mattress and an incontinence sheet in a plastic nappy, and that bum slips and slides, and that is what shear is. Okay, and shear combined with pressure now, because now I'm taking the fatty pad out the way, that pressure sitting directly onto the skin, that's when you're going to get your problems. So, what this lady worked out is an apple a day keeps the doctor away. Let's try and bring apples into pressure care. And she created this fantastic chart. I'm going to go through it a little bit now with you, and it is in your book, so you'll be able to take it home with you. Here you go, nice rosy apple. What are we looking at? The redness, okay? And we really want you to think about stage 1 is when the skin is intact, but it's red. And we use the word non-blanchable. Take your hand over here, press your skin. No matter what your color is, when you press it and you release it, it's going to go white and then go back to whatever color you normally are. When you press a non-blanchable, and I wish somebody would find another nice way of saying this, because it's not a nice way to say it. Non-blanchable means when you press the redness and you pull your fingers away, it doesn't go white. When it's non-blanch. Blanching is when you put something and you go white, put something into boiling water, you make it go white. You take cauliflower, you blanch it, you put boiling water over it, you'll blanch it, it turns white. Non-blanchable redness, it's very important to look for that. In darker skins, it might not be visible, but the color will be different from the other areas. So again, it goes lighter. You need to really be very aware of it going lighter. So you really want to look for that. It may be, here's some nice words, painful to the patients. And they're moaning, but you can't see that there's a big problem. But just that little bit of pain, you need to pay attention to what they're saying. But then again, if they're older, they feel less. Their nerve endings to the skin are not pampered and plump, so they may not interpret pain the same way. The area may feel firm. We like to use the word indurated, or it might be soft. And again, warmer is a very big warning. Cooler is a really big problem. And you need to do the touch test. I always say feel and then feel the skin next to it. If there's a difference, you've got a problem. I've got a fantastic thermometer that I measure skin temperature with, and I measure the pressure, the temperature over a wound, over an area I'm suspecting is a problem, and I'll measure the temperature somewhere else and I compare the difference. Thermometers are fantastic things that we don't use enough of. It might be difficult to detect in darker skin tones, but you've got to really think of who's at risk. Are they older? Are they sitting too long? Are they not drinking enough? Are they not moving? Are they not able to protect themselves? Those are your at-risks. Stage 2, just under the skin. Nice, like a peeled apple, okay? It's partial thickness and loss of the epidermis down into the dermis. So it's just when that blister happens and you're starting to see just underneath it. And you all know that that's that dreadful moment when you go like, oh, I've left it too long. Because you all know, once you see that, you're in big trouble. It's on the way out. With a red-pink wound and with or without slough. It may also present as an intact or open or ruptured blister, and presents as a shiny, dry, shallow ulcer with slough or bruising. But you don't use this to describe your skin tears, your tape burns, your dermatitis, maceration, or excoriation. So I've been into hospitals a lot, and what I find is that I'll go in and there'll be a patient there with burns, and they'll call it a stage 2 pressure ulcer. You need to be very clear that this staging is very specifically, thank you. This staging is very specifically only for pressure ulcering. What is stage 3? Look at that. Right down into the tissues, okay? And we've seen these stage 3s, and they make us very worried because we're not too sure what's next, and we know what's next because it's down to the dreadful stage 4. You've got full thickness tissue loss. You've lost right through the epidermis and into the dermis. It's like a nice big bite out of the apple. It's missing, okay? It's gone. It's subcutaneous fat may be exposed, but you can't see any tendon or muscle. It's just that fatty tissue that's missing. There may be slough, and then you might not know how much tissue's lost. And there may be undermining or tunneling. So very often you'll have a hole and then there'll be like a channel around the outside. We'll talk about that, I'll show you just now. So the depth and of a stage 3 pressure ulcer will depend on the anatomical location. A stage 3 ulcer on the heel that hasn't gone through to the bone will never be as deep as a stage 3 ulcer on my fat bum. So you've got to really know that there's a big difference. Okay, very important. The bridge of the nose and the ear and the occiput and malleolus don't have much tissue. And so sometimes those ulcers, even although they might look shallow, they will still be stage 3 because you've gone through the dermis. So it's very important to just remember that. No matter where it is, you have to stage it according to that area. And of course, obviously then, where there's lots of adiposity tissue, love it, fatty tissue, fat bums. But there's no bone or tendon visible. Very important difference between stage 3 and the dreaded stage 4. Okay, because the dreaded stage 4 is the core, right down. You're seeing bones, you're seeing ligaments, you're seeing those pips in your apple, okay? You're going to see stuff sticking out through the bottom of your wound, or when you probe it, you can feel a chip of bone. That's always my worst. You know, you put your finger and you go, oh, you just nudge right through and go, oh, it's right down. Okay. We've got full thickness tissue loss with exposed bone, tendon or muscle. Slough or eschar, which is black tissue, may be present and often includes undermining and tunneling. So then, like the apple core, it will travel under the tissues and you'll see a small hole on top and the bigger hole at the bottom, and we call it the iceberg phenomenon. Okay. Again, it depends on the area that it's on as to how much tissue you've got. And once you've got them, the biggest problem with exposed bone is bone infection. Osteomyelitis can be a huge, huge, huge problem. And it can all be palpable. Then your bruised apple. Don't you like the bruised apple? Okay? You can see over here, this I call the iceberg phenomenon. Okay? And I am really worried when you see a stage 1, which presents as a little redness on the top, that you've not recognized that it's gone all the way from the bone together. And you really need to be very careful when you see that doesn't extend all the way to the bone. And you don't know that when you see a deep tissue injury, what you're actually dealing with underneath. Unless that wound is open, you need to be very, very cautious when you classify something as a stage 1, and it's actually a deep tissue injury. And what happens is, it slowly opens up and suddenly you end up with your stage 4 pressure ulcer. So we call this a DTI, because of course this is written by an American, a deep tissue injury. Okay? And when you suspect a deep TI, you really need to make people be aware of that. It's got a purple or maroon look to it. It's discolored but intact. The skin or blood fold blister might show damage, but you don't know how deep the underlying tissue is. And you need to be really, really, really aware that what you're seeing on top might not be what it is. What sank the Titanic? An iceberg. How much of the iceberg do you see on the top of the surface? A third. 2/3 is hidden. And always, every pressure you see, you've got to remember what's underneath. What am I not seeing is the question. It's painful, firm, mushy, boggy, warmer. Those are the things that you really need to think about when you're looking at a wound like that. Difficult to detect in people with darker tones, but again, if your touch tells the difference, and we don't touch enough. How many of us go like, with our patients, and only with my gloves on, and you know, you need to touch. And if you can't feel through a glove, don't ask a man to wear a condom. It's nonsense. You can feel through a glove and you can feel through a condom. So don't tell me you can't feel the temperature. Okay, please. It may start out as a thin blister, but it is really important that you recognize that there's a dark wound there underneath. And a DTI evolves. It's the start. And you get a big panic on because you know what's going to happen afterwards is only going to be worse than what you're actually seeing and treating now. And then the stage that we all hate, unstageable. It's like a toffee apple with nice sticky toffee over the top. You got no idea what the state of that apple is inside, okay? We call it unstageable. It's filled. It's a hole that's filled with eschar and slough, and it's slimy and impossible to get in, or it's hard and you can't get through. We don't want you to call that a stage 4. We don't want you to call that a stage 2. As soon as that scab is in place, though, it is called unstageable. And we need to be recording these things as equals. When your next person takes over, they know that you've called this unstageable. It's a full thickness tissue loss, and the base of the ulcer will be covered with slough, which is yellow, tan, grey, stringy, green, brown, smelly, or with eschar, which is tan, brown, black, thick, hard scabbing. Okay. Until you've removed enough of that, you're not going to know what true depth of the wound is, and you need to make sure that that you know what you're dealing with. If there's no blood supply to that area, you leave that eschar in place. You don't fiddle, you don't start lifting, and you don't take it out. If you can't prove that there's enough blood supply to that area, you don't start taking it off. And I'm really talking about the fact that often when there's eschar over the heels, you might take away the natural cover that's protecting it. You take that off, you expose those bones, that patient dies. And you need to be really, really, really cautious with that. Okay? The body will auto-amputate that area if necessary. It will drop that scab off, or the toe will fall off. So just be careful when you see black, the term is unstageable. But, and I'm sorry, it's not over. That's all she presented in her paper. I have to chirp, because I do. I'm a very big chirper, sorry. There's a thing called IAD. Anybody? IAD. I think you had a workshop with me? No? Nobody? Anybody? IAD? Incontinence-associated dermatitis. You cannot put those 5 stages of pressure sores up and not add IAD. That's the soaking apple. Okay, all right. It is the wet, drenched apple that's been sitting too wet. It's that skin that's macerated. Okay, incontinence-associated symptoms include discomfort, pain, burning, itching or tingling, reducing the quality of life, worsening the frequency and quality of soiling. And IAD and pressure ulcers have a number of common conditions together. They occur in patients with poor health and with problems with mobility. Once the IAD has occurred, once that skin is wet, soggy, macerated like a wet, peeled apple, you can't stop a pressure sore. You've taken away the barrier and you've taken away the protection. In this country, every bag of nappies needs to have a barrier cream. How many of you are parents? So please, somebody put hands up. How many of you are parents? I'm not a parent. How many of you are parents? How many of you got kids? Ever not put a nappy on with a barrier cream? Ever not put some nappy cream on your child's bum? Why do we put adults in nappies without a barrier cream? Once the skin is gone, you can't stop the pressure sore. Okay, very, very important. The barrier function is lost. The inflammation and overhydration of the skin leads to the breakdown of the tissues, and you cannot avoid a pressure sore. This is the work of Professor Beckman. There's an international article on saving skins through IAD. It's an international paper that's been drawn up. There is no international ICD-10 code for incontinence-associated IAD. There's no code for it. The treatment of it is not recognized as a medical problem. How ridiculous is that? You can find nappy rash, but you cannot find IAD. And it's really a very important part of what we need to do, and you need to recognize IAD. This other lady called Karen Culp has gone and created a great learning process around the staging of these pressure ulcers, and to remind you what they look like, just because we've done the wounds and the ugly stuff. This is what she's done, and inside your bags is her crossword puzzle that Karen Culp created on this. And so to help you teach it and throw the stone further. Take that crossword puzzle and share it with those at work. You're going to find that they're going to learn quicker once the words are more comfortable and you're all recording and reporting in the same language. And that's